all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Rahul Banerjee from Seattle, USA, and he's going to lecture us on myeloma, the changing scenario. This webinar is, as usual, brought to you by Mumbai Hematology Group, supported by Jensen & Jensen, Unipath, Lucian, and Netco Oncology, and very well managed by Perfect Square. I thank Team Jensen & Jensen, Unipath, Netco, and Lucian, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Rahul Banerjee from Seattle, Washington, USA. All our discussants who are themselves eminent hematologists as well as medical oncologists, and you participants for sparing a Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 28th of September 2025, from 11:30 a.m. Indian Standard Time and 8 a.m. French Time, we have Dr. Delphine Ria from France speaking to us on chronic myeloid leukemia, certain difficult situations in management. Let me introduce our discussions for the day, and we have galaxy of them here displayed in alphabetical order. Just to name them, we have Dr. Aditi Goyal from Mumbai, Dr. James Khungar from Delhi, Dr. Jaswantini A.R. from Chennai, Dr. Jay Sheth from Mumbai, Dr. Jyoti Sawhney from Ahmedabad, Dr. Kunal Goyal from Mumbai, Dr. Mohammad Taha Ali Khan from Hyderabad, Dr. Meen Mohammad Hussain from Srinagar, Dr. Monica Chennareddy from Bengaluru, Dr. Sadashiv Gundeti from Hyderabad, Dr. Shailendra Prasad Verma from Lucknow, Dr. Sudarshan Pandit from Nashik, Dr. Sujay Reinschmer from Rajkot, and Dr. Vipul Sheth from Delhi. Now it's time to introduce our guest speaker for the day. We have with us Dr. Rahul Banerjee from Seattle, USA. Let me introduce Dr. Rahul Banerjee to all of you. Dr. Rahul Banerjee is Assistant Professor, Clinical Research Division at Fred Hutchinson Cancer Center, Seattle, USA. He's a member of International Myeloma Working Group. He's also the Chair, Content Committee, American Society for Transplantation and Cellular Therapy. He's also the member of Multiple Myeloma Guidelines Committee, as well as American Society for Clinical Oncology. He's also the member of, as well as of Plasma Cell Disorders Working Committee, Center for International Blood and Marrow Transplant Research. He's a winner, Health Tree Innovation Award and Health Tree Foundation for Myeloma in 2024.
Wonderful. Thank you, Dr. Amit.
Oh, again with us, and he's going to lecture us on myeloma, the changing scenario. Well, thank you so much. I stop over here. Over to you, sir.
Okay. Thank you so much, Dr. Amit, for that kind introduction. Let me pull up my slides here. See if we can get this to share. I think this is a both garv ki baat hai, but I'm very proud. My parents are very proud. I'm obviously second generation. My parents grew up in Kolkata and moved here to America 40 years ago. So it's very nice to be trying to help and learn from everything that I've learned from all of you and so forth. So some of you may know, Dr. Agarwal had talked with me about this earlier. So, I'll be speaking about something even more controversial, which is smoldering myeloma. What is smoldering myeloma and how we'll be focused on? Obviously, in the questions and answer session, I'm happy to speak about active myeloma. I'd be curious to hear from all of you about active myeloma as well. Smoldering is interesting in a lot of ways because no one really knows what it is. No one really knows how to treat it. So I'll go into some of that now. Here are my disclosures. And so, what I thought, I this probably won't take the full 45 minutes, but because I would love to spend more time just talking with all of you about this. So I think we can talk about what we agree on. There are some things that the whole world can agree on with regards to smoldering myeloma, and then a lot of things that we cannot agree on. And then I'll talk about some of the evidence for the two strategies for treating smoldering myeloma if one were to go down that route. Some call this cure versus control. I call it destroy versus deflect, and we'll talk about that. And at the end, I'd be very curious to hear about how this would apply for all of you in Asia, and particularly in India, obviously. But we can save that for the end. So first, what we all can agree on. So I think, all of you are familiar with this concept, right? So the word smoldering myeloma has been around for over 40 years and, it's evolving, right? So I think the big question here you'll see in 2010 at the bottom and 2013 here, many of you who have been practicing for this long remember that there was a time when SLIM criteria did not exist, where someone's light chain ratio over 100, or if they had more than 60% bone marrow plasma cells, but no true CRAB criteria, they were called ultra high risk smoldering myeloma. And they were moved to active myeloma in 2013. There's some controversies that come with that. I have patients whose light chains have been the ratio has been over 100 to 1 for years and have not gone on to get active myeloma. They've declined treatment and been fine, right? So there's some ambiguity there, but smoldering myeloma clearly has been shifting very rapidly in the last couple of years. There's the spinal things, and then here again, 2014 is when slim crab was defined. All of you are familiar with slim crab or crab slim, right? So crab criteria, unequivocal symptom, organ damage from myeloma. And then the slim are these things that aren't quite there, right? So 60% plasma cells, light chains. And if you do an MRI, if there's more than one lesion within the bone marrow, even if the hard cortical bone around the marrow is not affected, myeloma. This, I think, is also hopefully also practical in India because there's a lot of cost considerations that come into this. I think many of us remember an era where X-rays were considered sufficient for multiple myeloma. As I'll talk about now and also later in this talk, I truly do not think that they are sufficient anymore, right? I think that X-rays in general, you won't see anything on a true skeletal survey until most of the bone has been destroyed. And I think this is important. An X-ray actually is much more time for the patient, right? A CT scan, if you can get a whole body CT, not even a PET scan, a whole body CT is quick. Within 5 minutes you're in and out. An X-ray is much longer, uncomfortable for patients if they're having pain to have move things around. And I would argue not a dramatically reduced amount of radiation. So I would say whole body CTs, PET scans, or whole body MRIs are preferable only because, again, if you have someone whom you think is smoldering myeloma, and you do the CAT scan and it does show lytic lesions, then never mind everything I'm talking about for myeloma. All of you know this, right? Just to reorient the audience here, right? Smoldering myeloma is, by its very definition, a wastebasket diagnosis. You have the MGUS bucket that's very clear. You have the multiple myeloma bucket that's very clear, and everything else fits into smoldering, which is tricky. The reason for that, and this is a very nice graphic I'll show you here by Dr. Raj Kumar and Dr. Shajit Kumar, a couple of years ago, hematologist, because we don't know what smoldering myeloma actually is. So I'll put all three of these here, right? Three graphics to kind of describing what it could be. So graphic A is smoldering myeloma, something in between. Is it that MGUS cells in green become smoldering cells in yellow because myeloma in red, and smoldering is its own unique biological disease entity, truly? Is it scenario B down here, right, where you have at an individual patient level, you have some myeloma cells lurking like wolves amongst the sheep of smoldering myeloma, and slowly the wolves multiply, 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 and becomes myeloma, but there is no true intermediate state. It's more just a mixture of two things. Or C, instead of a mixture of cells, is it a mixture of patients, right? Where some patients with smoldering are just MGUS all along, and some of them already have myeloma, stage 0 myeloma. We just don't know it yet, and over time it will declare itself. We don't know. I truly, in my heart, cannot tell you what the answer is. My guess is that it's probably a combination of B and C, probably more than anything else. But honestly, it's difficult to say. We had talked a little bit initially doing audience response questions. I don't think it's worth to do it now, but I think it's worth discussing or just answering this question in your head. And I'll give you two scenarios here to talk about how would you approach this, right? So, I'm giving an option here. Let's say that you knew that your chance of developing active myeloma were 20% at 2 years. So by 10% risk per year, but only 20% chance over a lifetime. And let's say all these drugs were readily available free of charge. Daratumumab is available in India. Teclistamab is available at many centers in India. Let's say you had them, they were free, easy to do. What would you do? I'm just quoting some numbers here from the Quila study I'll talk about and from the CAR PRISM studies I'll also talk about here. So teclistamab works better, but a much higher rate of hospitalization and infections. Daratumumab is safer, but lower response rate. Would you observe or you treat as active myeloma now? My guess is that most of you, again, I will save time the question, I would probably choose option number C and say, let's just observe these patients and see what they do, which is reasonable. But then I've done this talk many times in America and once in Canada. When I change it to this, if you were told that you had an 80% chance, if you knew that there was an 80% chance, not 20% chance of developing active myeloma, which would you choose? And at least, in North America, I see many people change their answer from option C towards option B, right? If you knew this was coming and you had high certainty it was coming, you might change things accordingly. So I think the biggest issue, as you're kind of seeing, comparing this slide to this slide, is 20% versus 80%. Probably you start to change how you think about things. Your benefit risk ratio shifts. We don't really have excellent tools for prognosticating smoldering myeloma. We think we do, 20/20, et cetera. And we're going to talk about this, about how all of you triage smoldering myeloma, but it's tricky. There's a lot of stuff that's going on that we don't understand. And I think this is one of the biggest challenges of smoldering, that we don't really know what it is. what I think we can all agree with. So, obviously, I haven't talked to all of you, so I hope this is true. So I think number one, I think we all can agree that low-risk smoldering myeloma does not need to be treated, unless, of course, the clone is causing problems. Like if someone has AL amyloidosis from a smoldering myeloma clone that needs treatment. In the absence of that, low-risk smoldering myeloma, I don't think anyone is talking about treating, with very few exceptions. I think all of us can agree that high-risk multiple myeloma is challenging, right? I think it's interesting because in the US, we argue about this all the time. We're fortunate that we're able to talk about, giving daratumumab or not, et cetera. But it's really, a lot of it is not about the doctors arguing, it's about the patient's internal decision process here, right? I've had patients with smoldering myeloma who wish they had active myeloma, right? I had two patients that I can think of. One who had really bad osteoporosis and was really worried about bone fractures. And I was like, there's nothing I can do to get active myeloma. And she would keep kind of hoping that they would see something so she could finally get rid of this. And similarly, I had another patient once whose mother had smoldering myeloma and died. Her mother had myeloma, died of it. Brother had myeloma, had gotten transplanted for it, and sister had myeloma. She only had smoldering. And you can see that that's like a really hard scenario to be in. So I don't think there's any right answers here because every case is different. And finally, in terms of how we treat, or how we could treat smoldering myeloma across the world, if we were to do it, as alluded to earlier, the polite way of describing this is control versus curative strategies for myeloma. I like to use deflect versus destroy. And what do I mean by that? Some of you may remember this. I was at a year earlier this year, and I found that, I think it was a Times of India article here. Across the world, there was this question of this asteroid that was coming towards the Earth, and there was a question of, will it hit Indian cities? Will it hit any cities? Turns out, never mind, this asteroid is not going to hit Earth. But I think it's a very good analogy. If there's a 20% chance of this asteroid hitting Earth, or an 80% chance of the asteroid hitting Earth, what do you do to try to get rid of it? One option is obviously to do this kind of an approach, just some fancy satellite lasers or something, little rockets to push it out of the way, right? You're just kind of controlling it. I would say deflecting the asteroid so it's still there, still a little bit of a risk, but you're pushing it out of the Earth's orbit so it's not going to go hit us. And the other is this Hollywood movie some of you may have seen. This is the destroy strategy. Armageddon is, there's an asteroid headed towards Earth, and they go in, bury into the asteroid, and use a nuclear bomb to blow everything up right in their faces, and it still hits the Earth. So that would be the destroy strategy, right? The question would be, if you knew that an asteroid was coming towards the Earth, would you try to deflect it, or would you try to destroy it? And that's what I'll talk about. Let me start with the destroy strategy first. So the destroy strategy is what I'm describing here. This is basically eliminate every last smoldering myeloma. Think of Armageddon. Think of a nuclear bomb going in there and just blowing everything up. The quintessential example of the destroy strategy is this one. The GEM Caesar trial was a Spanish trial published by Dr. Mateos. She's published it several times, but this is the final update in the Journal of Clinical Oncology last year. And so you can see here, they took high-risk smoldering myeloma patients. Importantly, in this particular study, they did use CT scans or PET scans to rule out active myeloma. Prior studies there's one a bit of critique that some of the patients did have active myeloma because they only did X-rays to rule it out. Here's smoldering. You can see that these patients were treated quite aggressively, right? So here's KRD, carfilzomib twice weekly, lenalidomide dex, high-dose melphalan and transplant, consolidation, and then len-dex maintenance, right? If you weren't paying attention and you looked at this slide, you might say, oh, this looks like a multiple myeloma treatment slide. And it does, right? With transplant, consolidation, everything. Again, the destroy strategy at its finest. Here you can see a couple points here. So again, 23. So a couple things. So let's say here. So at the top here to highlight, they screened patients, but you can see 23 out of 126 patients, right? So almost 20% of patients who thought they had smoldering myeloma. Once you did the CT scan, you actually did have active myeloma. So I think it's worth noting that is imperative. X-rays, I don't think in 2025 are sufficient to rule out active myeloma. And jumping ahead here, that they talk about this being curative for smoldering myeloma. I don't know that it is, right? Even here, some of these patients did have progressive disease later on. Still a very low number, but it is true that some patients with smoldering myeloma, like those 7 patients, probably had active myeloma all along, and we just didn't really know. And there are examples where this KRD strategy was not sufficient for them. That being said, these are patients who are, fairly high risk, right? You can see a lot of them had met things by the high risk criteria. Many of them here had serum free light chain ratio over 100. We would call that active myeloma now, but at the time, this was more of smoldering myeloma when the trial was enrolling. Many of them had high risk cytogenetics. 57% of them had high risk by one of these abnormalities. So these are patients who are legitimately at risk of going on to active myeloma. The good news and the bad news. Here's the good news. So the good news, they looked at MRD negativity, measurable residual disease, and you saw really encouraging results here, right? So you saw that, 4 years out, about a third of them had maintained MRD negativity. Those patients are probably cured if you're still MRD negative 4 years after treatment. And you can see here that some patients did very, very well. And over here, they did a post hoc analysis looking back, and of the smoldering myeloma patients who had slim criteria, which is what we now call myeloma, you can't see legitimately that those patients, at least some of them, KRD, transplant, and Revlimid maintenance was not sufficient. For the patients who did not have slim, so just smoldering myeloma, no serum creatine ratio over 100, no MRI lesions, and bone marrow plasmacytosis less than 60%, those patients, almost none of them had any relapses, talking 5+ years afterwards. The bad news is safety. You can see here, this is a destroy strategy, right? A lot of toxicities here, lots of toxicities noted here, skin rash, infections, cardiac events, etc. They weren't convinced the investigators that the deaths were treatment related. I would say that they were, right? There were 2 patients who died from second primary malignancies. That can happen in the independence of anything else, but these patients got transplants, lenalidomide, etc. So I think this is reasonable to say lenalidomide and transplant have something to do with this. There was 1 cardiac arrest and 1 stroke. Remember, these patients were receiving carfilzomib, which is known to put people at risk of these toxicities. This is a big deal. In terms of how I approach it then, right? So I would say that if you were to treat smoldering myeloma like active myeloma, it's kind of like everything in life. Some do well, some do very poorly, and some people in the middle, right? So some people do really well. If you don't have slim criteria, the strategy certainly works. However, some patients still have active myeloma probably from the beginning, and those patients will end up having progression thereafter. Some patients die. So not great, because I think if you're taking an asymptomatic patient and they're dying from treatment, that is a problem. And so the question then becomes, well, maybe the strategy is okay, but the tactics were not okay. Maybe Gem-Caesar with KRD, transplants, et cetera, is not the way to approach this. And what if we had more modern tools? So this is data that were presented 2 years ago by Dr. Omar Nadim from Harvard, from Dana-Farber Medical Center and colleagues. And so here, this is teclistamab. Many of you are probably familiar with teclistamab. I know that many of the large centers in India have it. It is a T-cell engager shown here, similar principle to blinatumomab for ALL, but it's an actual antibody. One arm grabs CD3 of the T-cell, one arm grabs multiple myeloma cells by the BCMA, pulls them together, activates the T-cell, leads to myeloma cell death. And so they ran a safety. We don't have the randomized results here. We have a relative safety core here where they looked at teclistamab for these particular patients as monotherapy, as you can see here, for up to 24 cycles. So 2 years worth of teclistamab. I should add, if any of you were at the International Myeloma Society meeting last week in Toronto. I know I saw Dr. Uday there, Dr. Pankaj Malhotra was there. A couple of you may have been there listening to this. They did present a similar data with a different antibody called linvoseltamab. Same principle, a bispecific antibody typically used to treat relapsed myeloma, now being used for smoldering myeloma. It's very hard to define high-risk smoldering myeloma. You can see that they used a 2220, which some of you may be familiar with, and we can talk about that. They also use the original IMWG score, or they had this, an evolving pattern. And I don't know the protocol. I don't know what they used. I'm glad they had to look at this, and evolving pattern. All of us have had patients who don't look like they're high risk, but the M-spec keeps going up and up and up, and you get more and more nervous about them at a very high velocity. And so they had some of that, but again, it's a little bit tricky how you define these patients. So they looked at 19 patients. Most of them had about 20%, but some had 10, some had 55% bone marrow plasma cells. This toxicity profile, honestly, is very similar to teclistamab monotherapy for active myeloma. About half the patients got cytokine release syndrome. Tocilizumab was required. Infections did occur even with the use of intravenous immunoglobulin. That's kind of a safety profile. From an efficacy perspective, I do think this slide on the right is worth highlighting. In terms of the proponents of the strategy, this is what they point to, and it's a fair point to make, right? So what I'm showing here is the response rate, the CR rate, and the MRD negativity rate at the intent to treat. Out of all enrolled patients, how did they do? Let me start on the right. On the right is teclistamab real-world evidence. So this is, I should have put that in the abbreviation, sorry. Teclistamab real-world evidence published by Dr. Dima and colleagues last year, at least from the United States. I think like 100-something patients, I think. So 4+ prior lines of therapy, heavily pretreated patients, 66% response rate, and they didn't report MRD. The Majestic-1 study by Dr. Philippe Moreau and colleagues is what led to the approval of teclistamab in many countries, including India. That studied 3 prior lines. You can see a very similar response for 63%, and 27% of patients, of all patients who enrolled in the study, had diagnosed MRD negativity. In this study, small n, 19 patients, but for high-risk smoldering myeloma, 100% response rate and 100% MRD negativity. So all those patients probably are cured of the smoldering myeloma. You may ask, and I have to have the slide next. Oh yeah, I do. So how do I think about it? So I think if the strategy were to exist for smoldering myeloma, this would be it, because I think the toxicity profile was much better. There were no deaths from teclistamab here. This middle point is worth highlighting, right? Many of us assume that we're just taking drugs from active myeloma and borrowing them into smoldering myeloma. Teclistamab is really curious because truly it seems to work better in smoldering than it does in relapse myeloma. 100% response rate, 100% MRD negativity. This matches data from frontline teclistamab in the Majestic-5 study that Dr. Mark Robb was presented last ASH and at the IMS meeting. Same principle, that it seems to work way better in these patients. And a couple points why. One, for these healthier patients who haven't gotten transplant, haven't gotten a lot of chemo, haven't lived with myeloma for years, their T cells are more fit, more functional. And separately from this, there's less clonal heterogeneity, right? By the time that someone's gotten to 3 or 4 prior lines, there probably are some cells that are BCMA mutated or BCMA negative, and those can be the fodder for resistance. You don't see that in smoldering or active myeloma. So I think that's really encouraging, and that is the reason why bispecifics in smoldering or frontline, I think people are excited about, at least some people are excited about. But these toxicities are real. Any grade CRS, over half these patients would have to be hospitalized, many grade 3 infections. So I think it's just worth a discussion. Okay. Now I'll pivot to the deflect strategy. So now this is not necessarily to eliminate every last myeloma cell, but something different. There are many studies of this. So again, not KRD transplant, KRD, not teclistamab. This is more just let me just deflect the asteroid. Let me just put it into orbit so it doesn't hit the Earth. The other word is control. Let me just control the risk, kick that can down the road where the patient's still at risk of myeloma, but you've moved that risk window back by 20 years, and now the patient will live their whole life and not get active myeloma. Many studies of this, just to give examples, the KIRIDEX study is the first study I alluded to briefly. Dr. Mateos had published. It showed that lenalidomide seemed to have a survival benefit here, but again, many of these patients probably had active myeloma. There was an ECOG study led by Dr. Sagar Lonial and colleagues published a couple years ago looking at lenalidomide monotherapy, as I'll talk about. And then we have a study in the US and Canada, a cooperative group study looking at DARA-RD, so daratumumab lenalidomide dex versus lenalidomide dex, and saying, look, Aquila, they'll talk about was DARA versus nothing, but if you had lenalidomide, does DARA add anything? So in terms of the ECOG trial here, we'll start by talking about that. So for the ECOG trial, this is the trial of lenalidomide, right? This is the drug that's not approved in the United States for smoldering myeloma. But here it certainly has been studied. So here, just as an example here, so it's a 50% response rate for these patients getting lenalidomide monotherapy. Some patients achieve deep responses. There was no MRD negativity because lenalidomide did not induce MRD negativity by itself. PFS was significantly improved here. Importantly, I think it's worth noting that in smoldering myeloma, if you treat someone and the light chains or aspects start to rise, that cannot be considered progression. Like when you're talking about progression of a smoldering myeloma trial, progression must mean active myeloma. So they defined it as CRAB criteria here in terms of what the progression was. And you can see that that was better with lenalidomide versus observation, including in high-risk patients. On the other hand, even in the United States, where we give drugs that can be to everybody, we don't typically do this. Most centers do not do this. Most doctors do not do this. A couple points here. So a lot of safety data here, right? A quarter of these patients on the phase 3 component of the study had to stop treatment for adverse events. In the phase 2 run-in, there were 2 fatal AEs, including one PE, and that's like a big deal because that's very much lenalidomide associated. And then, as many of you know well from using lenalidomide for your patients, right, many issues with it. Even the grade 1 fatigue symptoms, rash, fatigue, arthralgias are problems. Financial toxicity in the United States. Ironically, this is worse in the US than in India. It's very expensive medication. Stem cell collection considerations. If someone gets 3 years of lenalidomide, you try to collect their stem cells later, it might be a problem. And then there was this question of an SPM risk. So here it wasn't powered for that, but it did seem a little bit higher with the use of lenalidomide. Again, for active myeloma, risk-benefit ratio is different, but here this is smoldering. I just want to make sure that we're taking our asymptomatic patients and we're not causing them undue harm by doing this. So is there a better path? So this was what I was asked to really speak about here. So this was the Aquila trial or the Aquila trial, looking at daratumumab versus active monitoring for high-risk smoldering myeloma. You can see Dr. Vincent Rajkumar was a senior author of this particular study. And here, many of you have seen this before. This was a study of daratumumab for 3 years versus active monitoring. This study was so old that this definition of smoldering myeloma is not what we would use today. Like, for example, I wouldn't say that IgA is intrinsically higher risk, but we'll talk about that. They did post-hoc analyses looking at what we call modern imaging. Everyone had to get a PET-CT or MRI to rule out active myeloma. And they were randomized here to DARA versus active monitoring for up to 3 years. Daratumumab. Everyone in the control arm got this at the bottom here. So they had to get blood work every 3 months, had to get some form of imaging once a year, and were required to get at least one bone marrow biopsy to look for progression. So it's not just that the DARA arm was being assessed more frequently, both arms were being assessed for progression. Their PFS here was, again, slim crowd criteria. So they allowed slim development to count as progression. But again, just a rising M spike alone was not considered to be progression. It would have to be something slim criteria meeting. I looked at all the different things, including PFS, etc. Here, not many of them were high risk. Only about a third-ish of them were Mayo high risk by our modern criteria, 2220. You can see here that from a PFS perspective, again, going on to get active myeloma or dying as the endpoint here, daratumumab did way better, right? You can see here that at the 2-year mark, 79%, 80% versus 3%, at the 5-year mark, 63 versus 41%. And these patients were monitored for many years, which is really significant. And you can see here, so nobody got fractures per se, but many patients did end up getting bone disease. So if you look at this, basically, this is kind of confusing the columns here. So, a third of the patients in the DARA arm still went on to get progression versus 51% active monitoring arm. And in terms of what actually looked like, there were some patients who developed new anemia, and that's okay. But there were some patients, you can see 10 versus 18 here, developing bone disease. So there were some patients in the active monitoring arm who got bone disease, not fractures per se, but actual bone lesions that would not have happened possibly if they'd gotten DARA. Here, this is more important. This is looking at what we would call the modern criteria. So modern patients with modern high-risk smoldering myeloma, smaller and not 190, but 72 and 86. Same principle here. Here, this is a good proof and principle of active monitoring. So on average, in these patients who had this, the median time to progression was 22 months. So many of these patients did go on to get active myeloma, but daratumumab not so much. Overall survival was met in this study. So this study did meet its primary endpoint, or not primary, it did meet the secondary endpoint of overall survival. So at the 5-year mark, 7% mortality versus 14% mortality, DARA versus active monitoring. And you can see that some of these deaths were largely due to disease progression. In terms of safety, lenalidomide we've talked about has lots of toxicities. Here, at least in this particular study, which was a global study, Dr. Hungary in Brazil, Dr. Thanopoulos in Greece, Dr. Kumar in the US, a lot of centers had this study open. The most common AEs were fatigue, neutropenia, and infections, typically respiratory infections. Unsurprisingly, if you look here, the second primary cancer rates were definitely high here. Here, in the ECOG study, it seemed that both arms to be lower, but remember that these patients were followed for much longer. So these patients were followed for over 5 years. So it's not surprising that many of them went on to get second primary cancers that probably obviously were unrelated to the smoldering myeloma, but just by virtue of being alive, they developed something else. This, I think, is an important slide that we don't talk about quite as much, but you can see here that for an asymptomatic condition, the first question is, well, does active treatment make them feel worse? Like lenalidomide, they didn't report this. So I would guarantee that lenalidomide will make a patient feel worse. Here, if you look at global health quality of life, the patients getting DARA actually were doing better. At the 3-month mark, look how much better these patients felt compared to here. Again, you may wonder, how is that possible? It's not that unreasonable. The patients on daratumumab are watching their disease barometers go down. They are, just feeling better psychologically about this. I'll tell you that I've had some patients with chronic fatigue, and they went on this trial, the DARA RD trial that we have, and they feel better. They're like, oh, my fatigue disappeared after starting treatment. And for all I know, those smoldering cells were doing something. We don't really know what, but there's probably some biological underpinning to this in addition to psychological effects. I'm kind of nearing the end here in terms of critiques and rebuttals of it, just to talk it through. And again, I would love to hear from the audience as how you approach this. So I think one question is that all these PFS events weren't real. The question that has come up was like, well, none of these patients had fractures. They had many of them, 10% in the active observation arm got lytic lesions, but no one fractured themselves, and so it doesn't matter. And I would be like, I don't think that's the bar we should be going for. I would say that the goal of smoldering myeloma treatment really should be to prevent any lytic lesions in the bones, not wait until someone has a fracture. There was no crossover. So I think this is a very valid critique that people talk about. So because this was a global study, many centers did not have access to daratumumab if the patient progressed to active myeloma later. Only about a quarter of them did. So that doesn't purely answer the question of DARA now versus DARA later. It was not intended to answer this question. The goal was to answer the question of um, singlet, like monotherapy now versus intensive transplant, etc. later. And I think that question has been answered, right? Because even if there's no DARA later, I mean, these patients are being spared VRD, transplant, LEN maintenance, all the stuff going on. And that's the goal of it. And that's what they're really investigating. There's a question that comes up that patients are being robbed of daratumumab. Many of us like to use daratumumab in the front line or more likely the relapse settings. You're like, well, if you get daratumumab early, that can cause us some problems because a third of them went on to get progression. And well, what are you going to do if they've already dara exposed? Again, this is a small n because most patients who get daratumumab will not have progression. Even the ones that do, many of them had happened many years out, like 5 or 6 years out. And so by then, the daratumumab is long out of the system and you can redo it. And plus, by 2030, induction will look different, right? I'm not as worried about daratumumab there. And then this is the biggest problem, right? The financial cost, the out-of-pocket cost for daratumumab is absurd. And so that is a critique of this, and I completely agree. So I think we need to fix this. We need to find, generic antibodies. Maybe in India, DST Jugaad say we'll find some cooler antibody that works, or we need a better risk stratification system to really identify who are those patients at high risk of progression within 1 year, and those are the patients you intercept with daratumumab. So things are changing. So a couple months ago, the European Commission did approve daratumumab for frontline smoldering myeloma. The US has not done this yet. Canada has not done this yet. Kind of a discussion being had. This doesn't mean that daratumumab is being used in each European country. It needs to be approved there, a step in the right direction. So how will I approach it once it's approved? So again, I think I'll use risk stratification, 20 to 20 high risk, but also this functional high risk category where, if we see something happening unusually where the M spike is rising and rising and rising, that might be the patient that I'm more worried about. We talked about this earlier. I think shared decision making is imperative in terms of values. What are they worried about? Comorbidities. Someone with really bad osteoporosis or really bad kidney disease may be more nervous about a high risk smoldering myeloma. May be reasonable to them. Obviously, financial considerations will factor into this in India. Like, can the patients pay for this? And then treatment. Yeah. So I think some patients I will offer daratumumab to. Haven't done it yet for anyone, but once the drug is approved here, I may. But again, the most important thing I would say is that you have to rule out active myeloma. Because if you don't, and someone actively has myeloma, and you give them dara monotherapy, you actually are harming them by undertreating them. So you have to make sure that this is truly smoldering, nothing for me to suggest active myeloma. So again, we don't have active response, audience response, so I'll skip over this, but I think it's just worth thinking out. You've thought about this. I'd be curious to hear what you think as all you think about this. And then if in the future you have patients in the scenario, talking to them, you may find that they have different values than you realize. So fine, in the last 5 minutes, I'll pause here, just open up some questions that I don't know the answer to, all of you know the answer to. So during the question answer, I'd love to get your thoughts. I think here in terms of just considerations with diagnosing smoldering myeloma, I think whole body CT scan probably is sufficient. I think PET scans are quite expensive. So I think whole body CT scans are very reasonable. The PET scans can pick out visceral extramedullary disease, like lymph nodes from myeloma, liver involvement, etc. That's pretty unusual in the frontline setting. So I think a quick head-to-toe CAT scan is fine. And then the MRI is a reasonable proposition. And, we are fortunate we have whole body MRI protocols that are able to be done. If that's not practical, that's an MRI focused on the bone marrow. I think just an MRI ideally of the skull and pan spine will be sufficient because obviously that's where most fractures occur. And then there was a nice review a couple of years ago looking, but Dr. Kapoor and colleagues looking at what fish probes to use. And I think these are probably the top ones there, 17P, 414, and 1416. Obviously, I would love to see 1Q get built into this, but if you're not there, you're not there. 17P is probably what I'm most worried about. That's about smoldering myeloma. With procuring daratumumab, so Aquila trial used subcutaneous daratumumab, just like in myeloma, weekly, then biweekly, then monthly. In terms of other things, I'm just saying all of this. Again, I would love to hear your thoughts. I think IV daratumumab is certainly cheaper than subcutaneous daratumumab, and there's no reason to believe that it wouldn't work. This trial did subcutaneous, it's just easier for patients, but the Columba trial showed that at least in relapsed myeloma, the two work interchangeable. The question of do you need to do it this way of weekly, then biweekly, and then monthly for 3 years altogether? Who knows? We're treating a precancerous population. You might not need that much. Obviously, they did what they did because they didn't know. But now that we know that that strategy works, can we de-escalate on it? I think it's reasonable to either do a Q8-week dosing. The Cassiopeia trial, for example, did show in active myeloma after transplant that Q8 daratumumab does carry a punch for these patients, particularly if they're dara naive. And then can you do 2 instead of 3 years, right? So we don't really know. It's interesting that this is a big discussion at the IMS meeting that if you're going to do a randomized trial now that daratumumab has been established as a standard of care, if you're going to try to look at these bispecifics and try to get them approved for smoldering, you have to compare them against this. So should you do a bispecific for 2 years and a daratumumab for 3 years? Should you do both for two, etc.? It's an open question that we don't know the answer to. And finally, with regards to giving daratumumab, so I think the biggest thing that I've heard from some of my colleagues across the subcontinent is the risk of infections that are particularly high in Indian populations for a number of reasons. So I think probably do what you do with active myeloma, even if you're doing time-limited therapy. I think you have to just be careful. So I think TB activation, infections, vaccines are all relevant. I think in my case, I would say, and Dr. Nikhil Kumar and Dr. Nikita Mehra have worked with me on this. I would say that if someone's getting a bispecific antibody, that intravenous immunoglobulin, IVIG, may be appropriate. For some of these patients, it may also be appropriate depending on their risk profile. And other thoughts I'd love to learn from all of you in the quality of the question and answer session. So with that, I will stop. I think a little bit ahead of schedule. Wonderful. This is the slide I always use for where I'm hoping in myeloma. Also by another Indian expat here, Siddhartha Mukherjee, wrote this nice quote that in 2005, a man asked me if he'd be able to watch his daughter graduate from high school. Then he watched her graduate from college in his wheelchair. Had nothing to do with his myeloma. He'd fallen down while coaching his youngest son's baseball team. That's the goal we're kind of hoping for with myeloma treatment. So with that, I will stop, and I would love to hear from the discussants and answer any questions and learn from all of you. Thank you all for your time.
Thank you, Dr. Rahul. Wonderful lecture, wonderful presentation. Hats off to you. So
Thank
I
you.
now request all our discussants to please participate for the question answer session and give a hand raise signs. So yes. So in the meanwhile, when the questions start pouring, sir, so in your practice, have you started for every patient with smoldering myeloma who are high risk with some form of therapy? You're muted, sir.
Oh, sorry. Yeah, it's a good question. So not yet. Yeah, I mean, I'm waiting for the FDA approval for it. I mean, technically, probably some patients I could try to make it work. I think it's tricky. I think, yeah, even when it gets approved, I think it'll be a small minority of my patients. It'll be the patients whom I think are both high risk and worried. Because all of you have had these patients. I have some patients who have multiple myeloma and they don't want treatment for it, right? Where they're just a little bit anemic and they want to observe, etc. So people go in all shapes and sizes here. So I think I will start offering it to people who are very high risk, and not all high risk things are created equal. I would say probably if they have, you know, at least 2 or 3 of the 2220 criteria and at least one high risk feature, particularly 17P. Those are the patients who make me nervous and they make themselves nervous. Those are patients where I may start to offer daratumumab to them. But again, I'm still waiting as well. I was kind of waiting to see what the approval shows, just because at least now in the US, I would not be able to get it approved and most insurance companies would be unhappy about it.
Thank you, sir. One question I have another. If the patient has already been started on, for example, say DARA, for smoldering myeloma or high risk smoldering myeloma, or you put the patient on LEN. And after some period of time, if the patient already progresses to multiple myeloma, don't you think, sir, that the DARA is lost? We have lost with DARA, we have lost with lenalidomide because the two important drugs are lost.
It's a
So
great
is it,
question.
is it
Yeah,
starting at this point because moment the patient goes into multiple myeloma, we have lost the two main important drugs.
it's a great question. So it is tricky. I would argue that if that happens while they're on treatment, that patient probably had active myeloma all along. And so that patient prognosis would have been poor to begin with. Um, I think most patients, at least in a trial, if you look at the curves in terms of when the actual progression events happened, most progression events happen towards years 2 or 3, or even further, like 4, 5, 6 years out. And by then, the daratumumab was out of their system. So I would say that, ironically, the nice thing about daratumumab monotherapy, let's say you start with that and the patient does go on to get active myeloma, probably they had active myeloma to that picture I gave, probably that patient's cells were active myeloma all along, if that makes sense. And so they were destined to require treatment regardless. And their VRD would work quite well for them. Yeah, so I do like the idea of dara monotherapy because I think it balances the idea of not putting all your eggs into the treatment basket now, and it's pretty well tolerated, saving your other drugs for later. But I think it's a discussion. And I think that's the kind of scenario where we would need to really talk through this more with the patient, but also rule out active myeloma. One of the very interesting things will be, on the other hand, you may be worried about over-treating patients, right? So some patients with slim criteria, so high light chains alone or something, you give them VRD transplant, treat them like active myeloma. I bet that in 10 years, we probably will be saying a lot of those patients can go back to smoldering and just get Dara alone. So I think it's hard. You're gonna have type 1 and type 2 errors, so to speak, on either side. Some patients will be overtreated, some patients will be undertreated. But I think that it'll be a minority of patients who are undertreated with Dara.
Thank you, sir.
Of
Dr.
course.
Vijay?
Good morning, Dr. Rahul. Nice talk.
Very nice to meet you,
Uh,
Dr. Vishnu.
there are a lot of facets to this diagnosis and treatment. So basically, mm, as we have seen, like during our residency until now also, we don't tend to see many smoldering myelomas in India. I don't know what is the reason. Mostly due to delayed presentation and patient don't present unless they are ill. People don't work up for M band, and even if M band is there, like M-band is done, they might miss light chain disease, like light chain disease as such. So we don't see smoldering myeloma as we see the discussion going on in West. We don't see that much, so that we are not worried. But one of a patient we get which wants to know more about it, and then we don't have an answer that we are trying to answer. So I would like to ask you if there is any data or if we can collate the data of how many trials of smoldering myeloma we have done decade wise, as in those, because in Indian population we see the myeloma presentation is a decade or so earlier,
I
and
agree.
the disease also tends to be very aggressive. So, if the smoldering myeloma presents in a younger age group, whether it tends to progress rapidly to myeloma and would require kind of carfilzomib type of, or maybe multi-drug therapy, rather than in an elderly patient who might progress very slowly, and considering his comorbidities, DARA may be a better choice, and it will push the disease more to 6 years down the line, when
Correct.
the comorbidities also will be more, and the disease biology of course will matter. Of course, if we have high risk features, we'll know, but can we stratify that on base of, like, basically majority of trials were done in Spain and US. So whether the disease biology in Spain is, why do they ask this question, whether they have more screening so they have more diagnosis of smoldering myeloma, or they have more presentation of patients who are either presenting due to some other complaints for smoldering and get worked up, and also whether they behave differently as compared to the patients in the US, which are
It's a,
like kind of older and they might progress a bit slowly, irrespective of, if we take out the genetics out of that, just I'm just saying the genetic in the sense the known genetics, high risk genetic features which we test for, if you take it out, is there any decade-wise stratification you would try to look into that? So that I was thinking more of that, if somebody is young And if you have to treat smoldering multiple myeloma in a young aggressive disease, better to give a full rather than going just dara, depending upon the resources, if the resource is not a constraint. And keep dara for those patients who will have relatively indolent disease, not like totally low risk smoldering myeloma, but um, in the high risk also, if they tend to have a slower progression of disease due to some markers or some age or some other disease biology which we can figure out, which is why you are doing all these studies. So would it change your discussion in that kind of sense?
Yeah, these are
I don't
excellent
know
points. Thanks.
if you understand what I'm asking. Like, I don't
I
know.
do, and I think there's a couple important points there. No, I do, and so I think in reverse order. So absolutely. So I think Dr. Lonial often makes that point. Again, it's like Indians everywhere. Sagar, he often says exactly what you're alluding to. That look like, you know, who would benefit the most from this intervention? It actually may be, to your point, the older, frailer patient, where if they get myeloma 6 years from now, they are going to suffer because they'll be in their 80s by then. So they might be the best patient to intervene on versus the 45-year-old. Whether they get myeloma treatment now or later would be fine either way. And I don't know that the age breakdown has been really looked at, and I'd have to go back and look. The best person to be asked, Dr. Vincent Rajkumar, but I will ask him, or if any of you see him, we should ask him because he loves treating smoldering myeloma, right? He was a senior author of that study, and he has thought about this a lot. You're absolutely right that in India, cases tend to happen, as you said earlier, more aggressive presentation, etc. And I'd be curious to see how much of that is age and how they've addressed it. Certainly, obviously, I hope that in future years, as SPEP becomes more widely available, I know that, people in India, like Dr. Nikita are working on like Malditov, it may be that someday mass spec is more available. I mean, I will say for me, half of my referrals for smoldering myeloma come from the neurologist or the GI doc or the allergy doctor who have checked an SPEP for whatever reason because a patient had some symptom and now they haven't, and they come to me. And I think in India, that's probably not quite as typical for other doctors to be checking random tests. And so that may change in the future. But these are great points, and I will get back to you on the latter one because it's a really good one.
So in our case scenario, usually what happens that even if you see the patient and you ask the test, they will not do. Even if it is $5 also, they will just keep it in the file. They will not do the test because they don't feel like it.
Fair, fair and fair. No, it's a different paradigm for things. Yeah, it's like the neurologist and the kidney doctor is probably check more SPEPs than I do. But it is what it is. There's some bads to that too. Yeah, you overdiagnose smoldering myeloma.
Thank
And
you. Yeah.
Dr. Amit, yeah, of course, I can answer some questions in the chat. I'll let you moderate, but I'm happy to
I'll just
answer
read out the
questions.
questions to you so that everybody. So, thank you, Dr. Vishwadip. One question has come from Dr. Kostub. How often should you do whole body MRI or PET CT scan in smoldering myeloma, especially in
Yeah.
high patients? Yeah.
Thank you, Dr. Costa. This is an excellent question, and we struggle with this in America as well, even with unlimited resources here. I would say for high-risk smoldering myeloma, I do try to do at least once a year imaging. I try to push for it. Honestly, for the patients who are like really making me nervous, where they're high risk and the numbers rising, I sometimes do an MRI every 6 months, like an MRI every September and a whole body CAT scan every March. So it's kind of alternating once per year, but it's every 6 months. Some of our trials do that as well. And if the MRI, even if the whole body MRI doesn't work, I would say MRI of the brain and spine, because that's what I'm most worried about. Again, that is financially a lot for patients. And then with the CT and PET CTs, there is some radiation that comes with it. And so I do like MRIs, right? They're louder and they're more expensive, but less radiation. So sometimes I have that discussion with patients. I think if they haven't had any funny business within the first year or two of smoldering myeloma, even if high risk, then I tend to back off because like most progression for high risk smoldering often does happen on the earlier side if with observation. And so, if that hasn't happened, they probably are not going to get active myeloma anytime soon. And then I might say once a year as needed.
Thank you. Another question is
Mhm.
from Devyani Joshi. Do you see a role of MRD testing in monitoring smoldering myeloma patients? And if you see, for example, tenfold change as a potential functional HR marker, your comments.
Oh, this is a fascinating question. So yeah, this is a next level question here. So normally MRD, right, measurable residual disease, is often used for like a yes or no binary approach, like do they have any cells or not? We often use it after treatment. So with the teclistamab, it is reasonable to achieve MRD negativity. You're asking about using MRD as a quantitative assay, not just a binary yes no, but oh, there were 800 out of a million, and now they're 2,000 out of a million, and so forth. That is possible. I think the only issue in my mind with that would be that just it is a lot of bone marrow biopsies, and I think here we're already asking a lot of our smoldering myeloma patients. If a blood-based assay became available, I would roll with it. I do think that there is an unmet need because I will say, and some of you may have had this, or maybe not, but I have had patients where I do all the right things, every 3 month blood work, MRI every 6 months. And I've had two patients, and they both haunt me because they both got active fractures. Myeloma came out of the blue between things, and then all of a sudden, here they were in the hospital, horrible fractures, etc. Maybe a bone marrow biopsies would have picked that up. It's hard to say because you would have to do it every 3 months, I think, to really catch that for some of these patients. So I think if a blood-based assay emerges, I'd be very interested.
Great. Thank you so much, sir. Another question is from Dr. Anli Dinkie. What is the role of steroid these days in smoldering multiple myeloma? Any role?
Great question. I would say generally not, because steroids come with their own side effects. I mean, yes, you're right. So like the RevDex trial, there have been old studies looking at it. I would say that, I would shoot daratumumab over dexamethasone. One, because it has fewer kind of the side effects of the anxiety and the sleeplessness, etc. And two, probably just works better, right? I view these steroids as really good short-term pulses to rapidly bring things down. I don't know that in smoldering myeloma, it would really add that much bang for its buck. It's cheap, but I don't think that it would add that much. The only exception would be obviously if someone has, you know, AL amyloidosis, some other reason to be treated. They're not steroids are very important as part of a pre-medication. But here I would say for smoldering myeloma, not much. For active myeloma, many of you know my research area, so like paper and blood last year was about dexamethasone in myeloma. That would be a story for another day because that's a different topic.
Thank you, sir. Another question, Dr. Karthik. How do you give bisphosphonate? Do you actually oftenly give bisphosphonates in smoldering multiple myeloma?
This is a great question. So many European centers do, most American centers do not. I get the sense probably in India, most of you probably do not, right? Is that fair to say?
We don't give,
I
sir.
see. Yeah, and I agree. I mean, I think just because, the risk benefit ratio, some of those patients are going to go on to not ever get myeloma, and bisphosphonate come with their own issues in terms of jaw osteonecrosis, dental issues, infusion reactions, time in clinic, especially with zoledronic acid, which is what we typically use. So I generally do not. Obviously, I think I would argue more important, and some of the older studies, so there was a UK study from over 15 years ago that might have showed some benefit there even before myeloma 11. But again, I bet some of those patients had active myeloma. If you actually were to do the MRI or the PET CT scan, in the modern era, those patients would actually have focal lesions. And so I would say more important to me than bisphosphonate for everybody is if you can get the patient to do the test, as Dr. Bishop alluded to, if you can get them to do this stuff, I think a full myeloma workout is imperative. And find those patients who have focal lesions or even suspicious anything. Those are the patients who have active myeloma or bisphosphonates are probably the most helpful.
Thank you, sir. So do you actually really think that in 2025, with all these drugs you have in myeloma, armamentarium, you have got DARA, you have got LEN, you have got bortezomib, you have got pomalidomide, you have got teclistamab. Is it worth that you must give bisphosphonate to all our patients who have been diagnosed as active myeloma in 2025?
That's an excellent question. So it's controversial, and here the European and American guidelines also diverge, and it's hard. I suggest it to everybody, but if they don't have lytic lesions, I don't force it, because you're right. Bisphosphonates come with their own side effects. Even in India, do you normally use zoledronic acid or you use oral pamidronate or IV pamidronate?
Use zoledronic acid and denosumab, both.
And okay, and also denosumab, right? So they have their own issues. I've had people get horrible calcium issues from it. So I typically say if they've had lytic lesions or if they're older, I kind of push for it, right? Those patients are probably a higher risk of bone demineralization. And so I kind of recommend that there. And for the ones with aggressive lytic lesions, I kind of push for it. But you're right. For the ones, especially nowadays, who are stage 1, asymptomatic, anemia only as their only criteria, I don't really push it. Or if you're going to do it, every 3 months. We typically do monthly for 1 year and then quarterly for 1 year and then stop. There's a patient where sometimes I told them just do quarterly, like do over 2 years, get 8-ish doses in, and then call it a day and you're done. But you're right. We actually don't. We're working actually on looking at this in our own institutional data set. And we found that it doesn't improve progression-free survival. There was a study in Norway by Dr. Frederick Schultzfeldt and colleagues showing that 4 years of bisphosphonates was better than 2 years representing skeletal events. But you had more osteonecrosis, and most patients didn't have anything. So I feel like it's probably overkill, and I don't use it that much.
Thank you, sir. And
Mm-hmm.
another question is from Dr. Emon Tent. Exactly what is the risk of overtreating the patients in smoldering myeloma? Number one. And if so, how should you balance this against delaying the progression?
Yeah. So I think the hard part is that we don't have good prognosis. If you knew 80% versus 20% risk of active myeloma, then I think it would be a very concrete discussion. We're not entirely there. I will say that daratumumab you probably could get away with half the dose there. You probably, honestly, you could probably do daratumumab. Many of you treated patients with daratumumab. The light chains drop like a brick, like immediately afterwards. It works so quickly. Same for amyloidosis that honestly, I bet that you could get away someday with a trial of 3 months of daratumumab and stop. There's a scenario, and some people view this as like this is not the same thing, but it's like, a colonoscopy, no one really argues with that. Everyone says, oh, colonoscopy, you're having stuff, there's some over treatment, there's some risk to it, but you're actually able to go in there and pluck out the polyp before it becomes colon cancer. This would be similar to that. Obviously, this is not a one-time procedure. In the study, it's 3 years of treatment, but there may be scenarios in the future where it's lowered. The bispecific antibody, just as an example, would be they're running studies now of 3 month bispecific antibody courses. That's still a long time, but 3 months of bispecific antibodies probably would cure someone's smoldering myeloma. You can manage the toxicities and then they're done and never have a risk. Instead of a 20% lifetime risk, this is 0% lifetime risk. So I think it's tricky because I think our trials don't reflect how these drugs will be dosed 5, 10, 15 years from now, especially as bispecific antibodies become more common and more affordable and more widely used across the world. But both that and Darren will be an interesting question.
Thank you. And one last question, Dr. Vishwadeep.
No, it's not a question. I was just thinking, like when we are treating smoldering myeloma, we are saying that we want to uh, treat whatever is not happened. And when we are saying bone disease and zoledronic, we're saying we should not give extra side effect to the patients who, like we are giving teclistamab, we are giving carfilzomib, we are giving lenalidomide, dexamethasone, and we are saying that we will not give zoledronic acid to prevent side effects. So, do you feel that there is a discordance between the two
Disconnect.
statements?
That's an excellent point. I think the difference would be that with daratumumab, there is a true, in the modern era from Aquila, a survival benefit, a PFS, a real PFS and a survival benefit. The data from bisphosphonates in the modern era are actually quite limited in terms of how well they work. And so I think that's the difference. Yeah, if
So, like
daratumumab was
if it is significant enough to be treated with daratumumab, can we couple zoledronic like like every 3 monthly with
Yeah.
that
Oh, I
and
see what you're
see?
saying. So you're thinking of give it to
Hmm.
everybody. Yeah. I'm
Hmm.
not opposed to it. I think it's reason. I mean, most patients probably could stand to benefit because it's like an insurance policy. So if you are wrong and they go on to get a lytic lesion, their bones are not much more
Like you
resilient.
said, your patients you are monitoring well, but they then got fracture. So whether like while with monitoring 3 monthly or 6 monthly, if we give a shot of zoledronic when they come to hospital, would that have present? Like we don't react to two patients in the bigger pool of pictures, but like I'm just saying like what we can do to prevent those incidences in futures.
I think this is an excellent question for an investigator trial. I might follow up with you guys about that. Actually, that's a really elegant point to think about it. There are data, just so you know, right, over 15 years ago, suggesting that bisphosphonates may actually help with direct myeloma control within the tumor microenvironment. All kind of questionable how relevant it is today, but yeah, it would have to be a lower dose intensity. I think both DARA and hyaluronic acid could be like once a month or once every 3 quarters or something. Um, Let me think about this some more. That's a great point, Dr. Bishop, that you brought up. That there's a contradiction there inherently that we can fix. This is cool. I learned something today. I've learned a lot, as always, from these talks.
Thank you, Dr. Kushu. Dr. Neem Thanda, your question.
Sorry. Um, Thank you for your talk, sir. I'm from Myanmar. What will you choose if the patient does not tolerate the lenalidomide therapy in smoldering myeloma?
Yeah. So for any of them, I would say if they don't tolerate it, I typically stop. Whether it be daratumumab or lenalidomide, I think, you're right. I have had patients who get infusion reactions to lenalidomide. I've never prescribed lenalidomide for smoldering myeloma. Some of my colleagues did and inherited their patients, and I'll tell you, most of them, I was like, "How are you doing?" And they were like, "I feel terrible. Like I'm fatigued. I have rashes. I have joint pains. My blood counts are low. I'm getting growth factors." And I was like, "Oh my God, we're done. Stop today." So I would say for smoldering myeloma, the treatment really should make people feel better. Again, daratumumab in the Aquila study, I showed you guys the quality of life. the treatment arm actually felt better because that's the kind of drug we're looking for. Lenalidomide would not be able to do that. So for Len, I think if they're on it, I typically stop it. One could argue that even a little bit of lenalidomide may have some benefit, but I'm cautious about over-treating them if you don't know that you're helping them.
Okay, sir. And another question is, how do you choose the post-transplant maintenance therapy? Whether to choose bortezomib or
Yeah,
Dara
it'll be an hour-long talk. It's complicated. I would say for transfer from active myeloma, in the US, for example, we typically say lenalidomide or daratumumab plus lenalidomide if they're MRD positive is where most of us are starting to move towards. Unfortunately, we don't really have good trials about len versus daratumumab plus lenalidomide. And I know in most of the world, daratumumab is absurdly expensive. So I don't know how reasonable that is. I would say lenalidomide is my backbone. And then if I don't have Dara, like before Dara, I would do for high-risk patients, bortezomib every 2 weeks plus lenalidomide to add that on.
Thank you, sir.
Thank you,
Of
Dr.
course.
So I think, sir, we have finished all the questions from the audience, as well as there is no hand raised signs. You have got a question. Yes, Dr. Kushu.
I just had a thought, like as we see in myeloma, when we treat, sometimes the patients have light chain escape. So would that be similarly seen in smoldering myeloma? Because then we would have to monitor, like most of the centers monitor all the three parameters together, like SFLC, IFE, and this also. But did you get my point?
I did. I do because we have light chains very readily available in the United States. But yeah, so I normally would. I will say that light chain escape should be less common in this scenario, in the same way that you're having much better response rates. Like Dara monotherapy, 63% response in Aquila. Dara monotherapy in relapse myeloma is like a 20% response rate. I mean, the point being that I think in later lines of treatment, these weird things like EMD, like radiographic relapses, light chain escape, all of that is more common. In frontline myeloma and then in smoldering, it should be less common because that patient, those myeloma cells don't know how to play tricks yet. If they do, that patient probably has active myeloma. Like if that were to happen, I never had it happen, I would say I would treat that patient very aggressively because something is weird going on. That's unusual.
And EMD, like if you're giving like one drug instead of three, so shouldn't be EMD more at risk rather than less at risk?
Yeah, so if someone has EMD, obviously if they have EMD, I would not treat them with just Dara alone.
No,
Obviously.
I'm just saying, like because the follow-up is kind of spaced out as compared to myeloma, you tend to hit hard and monitor more closely. When you're treating smoldering, you might give it like a longer 3 monthly workup and like MRI every 3 to 6 months. Like it is not as protocolized as we do in myeloma. So there might be new EMDs which might be missed unless they are symptomatic much more
Agreed.
than we do in myeloma, because we are always alert that there is something can happen.
I agree. We'll have to do more real world studies. Hopefully, should be uncommon. Again, some patients that even in the Dara arm did get EMD with the once a year scans, no fracture. So for what it's worth, at least in that model, there were no patients who had symptomatic EMD above and beyond the once a year imaging. So I think it probably would still suffice. I don't want to overdo it, but I agree with you. I mean, ideally, we would look at these patients more, and if they do have any weird lumps, bumps, pain anywhere, should be identified.
Thank you, Dr. Kushu. And last question from Dr. Bhuvesh Gauri, please. Dr.
Thank you. Dr. Rahul, a very basic question. Do you have a vaccination schedule before you start somebody on deflect regimen for smoldering myeloma?
It's an excellent question. So thank you, Dr. Bhavesh, for saying that. I can't say that we do yet. I haven't actually thought about that. We do recommend for all my patients getting daratumumab for active myeloma, I do recommend kind of the flu and influenza, COVID, et cetera, beforehand if I can. It's a good question because daratumumab, I wouldn't mandate it per se. Obviously, I don't expect daratumumab to cause someone to lose their childhood vaccines, for example. But I do agree with you. I think if you're going to go down this road, it's almost like doing an elective splenectomy. You tell people to get your pneumococcal vaccines ahead of time. I would say here, you are starting daratumumab, get your vaccines ahead of time just in case. But I have never actually thought about that. That's a really good question. I will think about this some more. Monthly Dara shouldn't dramatically impair humoral responses. But you're right, COVID vaccines don't work as well when someone's even on once a month daratumumab. That's a question that should be answered. Thank you.
Thank you, Dr. Gauri.
Thanks.
Yeah, so I think your time's up is up, sir.
Okay, it is. I can hear my child is already screaming. I told him 7:30. I would love to come back for round 2. Thank you all for your time. This has been lovely, and I've learned a lot from all of your thoughts.
Thank you so much. And sir, one request to you. Mr. Hitesh Khandelwal from India wants to connect to you after we all log it out. So just to have a chat with you for 5 minutes. So please give time for 5 minutes.
Okay, I can take a little bit longer, of course.
Log it out and let Dr. Hitesh Khandelwal connect to you. Just be stay
Okay.
on. So yeah.
Or what I'll do is I'll also give you my email address here if I can have help with anything.
Yeah. So Dr.